prostate cancer tends to be what we call multifocal. In other words, there can be several spots of cancer within the prostate, and it's multifocal actually in about 75% of men. And it's also heterogeneous, meaning it's not uniform throughout the prostate. There may be an area of low-grade cancer in the prostate, and if you biopsy that, then you falsely may lean towards not having any immediate therapy because you assume that it's a low-grade cancer, whereas if the needle happened to miss the high-grade component, then you may suffer its consequences. Now, if you look at patients who've had a biopsy and then have gone on to radical prostatectomy that are reported in the literature, for instance, in the UCSF cohort from Peter Carroll's group, the upgrading and upstaging was in 31% of the patients. If you look at the Walter Reed cohort, it's 41% of the time. Again, so it depends. As I said, it's anywhere from the low 20% to the high 40s or the 50% range across a variety of series because different patients in each of these cohorts. To give you an example is that if you go into a doctor's office today and he's looking at a biopsy of your prostate, a random biopsy that has 2 or 3 cores of Gleason 6 disease in it, the doctor knows that there's a significant chance that that biopsy report does not reflect what's actually in the prostate. And depending on whose series you look at or what paper you read, that likelihood that it's misrepresenting what's in the prostate is perhaps as low as 20% or as high as 50%. So when that patient comes in and you're sitting across from him and you tell him that he has prostate cancer and he said, well, how representative is this biopsy of what's in the prostate? You can't give him a specific number. You can give him a range and you can say, well, we may be missing the high-grade disease 20% of the time or perhaps up to 50% of the time. And that's a wide range. So patients would like to know if they're in the 20 or if they're in the 50 because that's going to drive decisions.